as I say, unless and until we as a diagnostics community can provide a coherent, unified, consistent, persistent voice and address what we see the issues are in a coherent, consistent, persistent way, it's going to be very difficult. So we need unified leadership, unified messaging, unified action.
Do we need to rethink diagnostics as an economic and industrial issue, not just as a health issue?
Yeah, absolutely.
Is that possible? Yeah,
absolutely. I've been trying to do for the last, I don't know, number of years now, is to try and get some sort of defensible assessment of the economic impact of accurate, timely diagnostics in our healthcare system. I have personally no doubt. My gut feeling is that this must be true. And therefore, if we could somehow capture and turn that into, as it were, dollars or into percentage of GDP, I think that would be a really powerful thing to do in terms of getting the message about diagnostics being an investment at not a cost.
Welcome to Inside Diagnostics, where laboratory science meets the real world impact. I'm your host, Anafi Mataka. This is a space for conversations on the ideas, systems, and leadership shaping the future of diagnostics. The Lancet Commission helped place diagnostics firmly on the global agenda. 5 years later, an important question continues to remain. Are we actually making progress? In 2025, an update from the Lancet Commission explores that, highlighting areas of progress, persistent gaps, and the realities shaping diagnostic systems globally. To unpack this, I'm joined by Professor Kenneth Fleming, who is the lead author and chair of the Lancet Commission on Diagnostics. Ken, welcome to the show.
Thanks very much, Anafi. Great pleasure to be here and to talk about this really important and difficult problem.
To get us started, when you step back, how would you summarize global progress on diagnostics since the Commission?
I think the answer is clearly it's patchy, and that's for quite a number of reasons. Probably the most important thing to say right off is actually this is a really long-term, difficult problem. There are no quick fixes, no silver bullets. And I've sometimes, when I talk about this, I say this is a 30, 50-year problem. I mean, there are really significant issues around about addressing it. So I think it's probably first to recognize is to expect very quick answers really is unrealistic. Having said that, there are some areas where we have made progress, and we can go into that a little bit in detail later, but getting more advocacy, getting it more on the agenda, I think we have made some progress there. There has been some progress on particular things around essential diagnostics list. And I think in one or two areas as well beyond that. But in general, some of these issues, for instance, workforce, that's going to take a long time. Workforce is a key issue. No point in having equipment, etc., unless you have trained, qualified people. And getting that done takes time to train people. Issues around affordability, that's a big issue. It's all very well having tests available, but in fact, if people can't afford them, then that needs to be addressed. And we're way behind therapeutics. Many years, medicines have devised ways of perhaps bulk procurement, joint procurement, and other devices to reduce the costs overall. And I guess we have to look at that, but that requires probably global action, certainly concerted action over a wide area. So I think it's been patchy, some progress, but other areas, not so much progress. And I say that's partly because it's just as difficult in the timescale, but also there are other problems as well.
Yeah, thanks. Exactly like you said, I think 5 years probably is not a long time to make that progress. But you find that the change has been uneven in many areas. You mentioned workforce. Can we say this is the greatest bottleneck right now?
Actually, my personal view is it's probably, if it's not the greatest, it's certainly one of the greatest. There's no question about that. And I think quite a number of people have been involved and interested in this project, have seen quite a number of places you go to visit, for instance, hospital departments or other areas. There's equipment there, but it's not in use either because they don't have a trained staff. Related to that is quality control. about how you ensure that whatever you're doing actually is of the quality required. Uh, yeah, I mean, workforce is really a key issue, but it's related to the whole issue of diagnostics. Getting recognition that diagnostics is fundamental to efficient and effective healthcare, and that it's properly resourced to do that. But yes, I think workforce is a really key issue, but it's just part of, as I say, the general message about you have to put time and effort and money eventually into diagnostics to get the benefit down the line, but it will take time. And for instance, I don't know about your training period, but I was at university for 6 years. Then I trained in pathology for an additional 5 years to get my senior qualification. So that already is 11 years.
Yeah.
Plus, had done a year or so house jobs in clinical practice. So you're talking about 12, 13 years. And that's even before I sort of start. And that's clearly unsustainable in addressing the huge problem of workforce. And I'm talking about as a medic. But even for the scientists and the technicians, it takes too much time to get people trained. So we have to find some ways, perhaps, of task shifting and so on. And people are looking at that. But workforce is a big key issue. And my personal view, I'd like to see some of the regulatory or institutions that look at standards within diagnostics working together to work out how can we have, for instance, I don't know, a 2 to 3 year training program, which would qualify people to do certain, perhaps relatively constrained tasks within diagnostics, and which would become universally applicable, covering the key core concepts and skills necessary. But that has not happened yet. But yes, so the basic problem, you're absolutely right. Having said that, diagnostics is not unique. I think it's generally true in healthcare across the world. Workforce is a key issue all over the place. So it's not like I think we're particularly disadvantaged, but it is a key issue.
Just to follow up on when you say you want to train a cadre, which if I pick you right, it's more of a multidisciplinary kind of cadre to kind of cover as many areas as possible. How practical is that?
I see in recent why that couldn't be the case, why you couldn't train people over a 2 or 3 year period. So, for instance, just take, I don't know, nurses, for instance. If you take the training program, they have maybe 3 years or so, but that covers all sorts of different disciplines within nursing in healthcare. And I don't see why, in terms of diagnostics, why we couldn't have diagnostic either, as it were, clinicians or the scientists looking at training across a broad range. In fact, when I trained as a pathologist a long, long time ago, admittedly, I actually did my first part of my professional qualification at Royal College of Pathologists. I did it in 4 disciplines. Histopathology, which was my specialty, but also in microbiology, in clinical pathology, and in hematology. So that's people were being trained across multiple disciplines, albeit 40 or 50 years ago. But I don't see in principle why we couldn't put in place training programs which had a similar approach. And we've gone to super specialization a lot in healthcare, which has great benefits, of course, for the patient. But in terms where you're looking at a key issue around workforce and the sheer gap we have in a long time it takes to, and the expense to train somebody in specialties, I think we should certainly look at more generalized training.
Yeah, that makes sense. And I can relate to that. When I trained my primary degree, it was more of a not special, like you are training in all the disciplines, hematology, clinical chemistry, microbiology, and you are able to move in between. Man, that
plus, I think it's probably worth saying as well. And I think actually getting insights into the issues around those other disciplines actually helps you subsequently if you do specialize in to understand some of the problems of hematology or microbiology. So actually, it's not. It's not as it were a second rate or an inferior option. It has potential advantages apart from the obvious time and finance.
Yeah. It's clear that this is an issue, but particularly in workforce. And you also mentioned affordability. Is the training and maybe approach that we are not doing right? Why is progress slower? Are there any other reasons why progress is slower?
Well, again, couch my remarks by saying, actually, it is intrinsically a lot of the issues are very long term and going to take partly a capacity, but partly just simply, again, it takes time to address some of these issues. At the end of the day, my personal view is that actually, and there's some evidence from what's called the Gates People Fund and looking at comparing countries that had done well in implementing certain tests, etc. It appears to be one of the key issues, political will. At the end of the day, if we don't get the ministers of health, the ministers of finance to recognise that diagnostics is really integral, central to effective healthcare, and therefore put the appropriate resources in to put in place good and effective systems, it won't happen. And I think that's really partly an issue, or mainly an issue around advocacy, getting the fundamental importance on the agenda to ministers of health and to ministers of finance. Now, I understand they've got lots of problems, many priorities, many crises. It's very, very difficult. And, it's regarded as not a frontline clinical service, which I disagree with, but there again. So I understand it is difficult, but that's our job, in my view, is the job of ourselves, people who actually work in diagnostics, to make that case. And I think that's one of the problems in the past. For whatever reason, we've been a bit of our own worst enemy in some ways. We have not actually shouted and made the case strongly enough. I think that's starting to change, partly the likes of the Lancet Commission and others, but it just takes time. And of course, the World Health Assembly resolution of 23 was helpful in getting that onto the agenda of WHO, but translating that into effective implementation in different countries is another issue. My personal view is this is an interesting thing about WHO. My sense is there's can be a lot of resistance to messages coming out of Geneva, and countries just thinking, well, why should we listen to what they tell us what to do? So
why do you think that is so?
I think that's just intrinsic to any big system with lots of parts. We have a centre and a periphery. There is always a tendency for the periphery to feel that the centre doesn't really know what's going on, and they're the ones that are dealing with the daily problems, and they should resist it. And so my proposal around that is that there should be much more, if you like, regional messaging and advocacy. I would like to see regional groupings getting together and actually, ideally at a national level, but certainly at a regional level, so for instance, some parts of sub-Saharan Africa getting together, Southern African region, for instance, getting together and saying, let's get together and put in place a 2-year plan to make the case for diagnostics in our relevant countries. That's probably going to be more effective in the long run than stuff coming out of, for instance, of Geneva.
Yeah, that makes sense. There's power in numbers, but numbers that are closer to the situation.
Yeah, and they know the people and they know the particular problems which are relevant to every country, somewhat different. So I think it's more likely to the politicians in the healthcare and finance will listen to people they know and respect rather than messages coming from abroad. So I think there is something that could be done around looking at more regional activity, taking on the case for diagnostics, making the case for diagnostics.
No, that's quite a very important point. You kept on mentioning political will, prioritization. Has diagnostics, according to you, truly become a priority?
I think it's patchy again. I think some countries it's become more visible, other countries not. And I think that, and of course, particularly in the last, 2 years or so of global health, the funding situation has become really very, very difficult.
Yes.
And it has had an impact across many areas, not just diagnostics, but it doesn't help. And of course, because diagnostics has always seen a bit of an orphan for the reasons we've partly touched on earlier. I think, diagnostics really is, to some extent, getting squeezed out when people are fighting over whatever limited resources there are. And diagnostics becomes less of a priority again. Again, that's contingent on us.
Yes.
Us people who are interested in this, getting involved and making that case. And again, I think, we could do more ourselves.
Good indeed. I would like us to move on to one key component that has been mentioned in the update, where you are saying progress normally happens when diagnostics aligns with industrial policy. Can you unpack that?
Well, it depends what you mean. I think probably India, in some ways, is a really good example of this. India, for whatever reasons, quite a number of years ago, clearly decided it in terms of economic areas that they would make a special thing, and they've now become the global capital of generic medicines.
Yes.
Vaccines, I think they're the biggest individual supplier of vaccines around the world. And they had this initiative a number of years ago now called Free Diagnostics, where we funded diagnostics. And related to that, the manufacture around diagnostics has become significant activity in India. So I think there was a government policy in India to look at an economic benefit for focusing on healthcare and aspects of healthcare, and that diagnostics has benefit in that. South Korea, they've made a big impact on particularly in the imaging area. And so I think what again it's demonstrating is that if there's political will to invest and support, facilitate, foster particular industries, particularly around healthcare and within that diagnostics like imaging, then you get more progress more quickly. So I think that's really, I think, what if you can align that type of political decision about where they want to put the resources in developing the economy with the issues around diagnostics, that can obviously benefit.
Yeah. No, I think, that's also quite important, really aligning that and making sure that it speaks to the politicians themselves.
Well, again,
For us to be,
sorry to interrupt, but again,
Yeah.
what that is getting a message to the politicians. Actually, there are economic impacts and benefits if you invested in this area.
Yes.
So it's again contingent on ourselves to get on with it.
Yeah, exactly. Yeah, that's what I was going to say. Do we need to rethink diagnostics as an economic and industrial issue, not just as a health issue?
Yeah,
Is
absolutely.
that possible?
Absolutely. I remember I talking to a guy called Mark Dyball, who was very central to getting HIV and developing therapeutics for HIV 30, 40 years ago. I remember talking to him about how he managed to persuade politicians that HIV was an issue that needed to be addressed and invested in. And he said one of the key things was getting hard data, economic data that showed that there was an economic benefit from providing better healthcare in HIV particularly. And so that's very interesting because one of the things I've been trying to do for the last, I don't know, number of years now is to try and get some sort of defensible assessment of the economic impact of accurate, timely diagnostics in our healthcare system. I have personally no doubt, my gut feeling is that this must be true. Very interesting statistic, Greg. It was in, might have been Nature or Lancet some months ago, looking at cases of diabetics in India. And there was an estimation that the population, something of the order of 40% of people in India potential for diabetes. The majority are a significant majority undiagnosed. And if you look at the long-term impact of untreated diabetes, it's quite clear there must be an economic benefit for diagnosing these people earlier.
Yeah.
And I think that principle must be true. And therefore, if we could somehow capture and turn that into, as it were, dollars or into percentage of GDP, I think that would be a really powerful thing to do in terms of getting the message about diagnostics being an investment at not a cost.
Yeah, we should put it in the lens of the return on investments.
Exactly.
And probably this is the messaging that we need to give our lab leaders as they talk to because most of the time we are always looking, which is fine. We are always looking at a healthy, the classic definition of health. It doesn't mention health, social, and well-being, but we leave out that sort of return on investment component, which anyone who's holding a purse of funds and they have to prioritize. They always look at what we return, but we need to do that. I think I agree with you that there is so much shortage of data and evidence in that area. Yeah.
Well, we in the Lancet Commission, we did some estimates of the tracer commissions, and all of them were positive, I think, if I remember rightly. And some of them had returns of over 20 to 1, depending on the condition. So I don't have any doubt that if we can do this in a, as I say, a defensible, accurate way, then we will show. There was a very interesting paper from a report from the OECD about, I guess now, maybe a year or two ago, looking at diagnostic errors and the cost. Now, that's not the same as a lack of access to diagnosis, but it's basically saying that if you've got a poor diagnosis, there's a long-term economic, socio-economic impact. And they had very large numbers which were produced in that. And I was talking about, I think it was something in the order of 15% of health spend could be saved if diagnostic errors were reduced. And it seems to me that's highlighting, well, it's not completely analogous, but it's highlighting if we can demonstrate the socioeconomic impact of diagnostics. We had a very powerful case for the Minister of Finance to look at to say, you will get a substantial return on your investment.
Yeah. And this requires government buy-in. You mentioned Brazil in the paper, and you also mentioned India here as we discuss, and South Korea. What role does government play here? Maybe probably government in the donor sector. Yeah.
Well, as I said already, I think it's crucial. No, I mean, it's not the government's not the only game in town, obviously not. But put it like this: if the government is not identifying diagnostics as a priority, then it's very difficult for anybody, either local, nationally, or even regionally or internationally, to do much, get anything effective, because simply they set the priorities. So it's something of a sine qua non that the government and the political rulers in charge at the time has to recognise it's an important issue and that resource needs to be into it. So I'm quite clear in my mind that if we're going to do anything, advocacy with governments and policymakers and funders, that this is a key issue for better healthcare, but also it gives you an economic return on your investment. If we can get that message clearly produced, as I say, in a way where the numbers are defensible and persuasive, and then going to governments and saying, look, okay, it's not a quick fix, it'll take you time. You have to train more people, you have to put more equipment in you, etc. There's a whole lot of issues. But in the longer term, it will be better and you get more value for your money. Currently, we must be wasting lots of resources on, for instance, on therapies which are the wrong therapies. So when you've got a situation where you're dealing with limited resources, it's really very important to try and make best use of that, and having accurate, timely diagnostics is a key component. And we have to make that case as strongly as we can. And I think that's probably the single most important thing we can do in the long run. But to support that, we need to do things like, what is the economic impact? What can we do to reduce affordability or improve affordability? What can we do to reduce our training programs, make them cheaper to set up and to get more people trained in a shorter period of time? So things we could do to make our own house in order, but we have to do that in parallel and partnership with governments to say that, if you put resources in, come with a solution and say, this is where things could be better. And here's why it should be better. And please help us to do that.
Yeah, thanks. And indeed, the government really plays a key role here. And I want to connect your earlier point on regional efforts as well as things coming from the global stage in this funding paradox. The WHA passed that resolution, but if I'm not mistaken, there is no financing mechanism that has been proposed kind of there. So is coming back to the recommendation on financing, does this remain wishful thinking without that global diagnostic fund? Do you think it's something that is doable?
I think it's doable. I think you have to be. Well, put it like this. I've often said, and often I genuinely believe this, if we could make the case to patients in a way which says to them, you know, you should be getting your diagnosis in a day or two or three rather than weeks or months, or we should be, there should not be diagnostic errors or the maintenance and all the rest to it. If we could make the case to them, they were. I don't think our patients would support us and put pressures on governments to improve diagnostics. But again, that's part of any advocacy policy. It's interesting. I mean, going back to WHO. I mean, one of our recommendations in the commission was for having some sort of global alliance, a global coalition. And in fact, just over a year ago, I think there was a global diagnostic coalition was launched at WHO in Geneva last year. Now, the first meeting of that group is actually going to be in a couple of weeks' time, I think it is.
Yeah. Yes.
May the 25th. So it's taken a long time to get things going. But I think I see that rightly or wrongly, that group taking the long-term responsibility for providing the leadership, helping to pull people together in different countries, different regions. How do we maximize our bang for our buck? Where are the areas we should focus our activities on? Not just advocacy, but affordability. How do we persuade countries that they should have a national diagnostics plan? How many have that at present, and so on. So I think if the coalition, I would hope that it can get going and take these long-term problems in hand. So go back to workforce we mentioned earlier on. It would be really fantastic if the coalition pulled together a group to say, how can we plan a 2 to 3 year multidisciplinary training program which will fit both the scientific and the clinical people together to provide a quicker, shorter, cheaper, but still effective diagnostics workforce would be fantastic. And to get training programs which were then recognised in many different regions and countries. So coalition, I think, I'd like to think it's going to be really important, plus having a role in continuing advocacy for us.
Right. It's diagnostics work in a network, and the more efficient the network is, the hopefully less funds can be used within the network. One of the recommendations that you had in the commission is on integrated networks, essential diagnostic lists. How much progress has been made in that area?
That's one of the areas where there has been quite a lot of progress in the essential diagnostics list. I don't have the latest figures now, but when we actually did our commission, I think it was one country or something like that.
It was just one country back then.
Had an EDL. And now there are, again, I don't have the most recent list, so I couldn't but there was something like 14 countries had programs in place to develop an EDL. And I suspect quite a number of them, since I last looked at it, which is probably maybe 2 years ago now, that's probably they have developed. So there has been quite a lot of progress. And I think it's interesting that countries and people have sort of understood that concept and realized it's a practical way of making progress. And so that's really been quite successful. Going back to the question, the EDL is what we propose should be part of an integrated network of diagnostics, because clearly you have some diagnostics which are needed at primary care level, community level, and then you have others which are much more complicated and expensive and higher skills needed, which can be provided only in hospitals or even central hospitals. But they should all be part of a single integrated network. Partly because you can share information and data about the patients back and forward across the network. But also, for instance, you could be having your training program for your workforce, quality control. They could be shared across that network. And so that instead of 5 hospitals trying to train their own people, for instance, you could have one training program which covered people who are being community health workers, could be part of that training program, but working in the community, but also be part of the training program, for instance, for the hospital. And I think there are long-term benefits from exchange of information, but also efficiency of financial efficiencies. So again, that would be interesting to look at. And some countries have developed integrated networks, but I think, this has been recognized for, I think, since even the Maputo Declaration way back 20 or 30 years ago. the integrated diagnostic systems were important. But again, progress has been slow, but we have to keep trying.
Some critics have said availability of a list, for example, maybe we can take lessons from essential medicines list. Does it necessarily mean availability of diagnostics?
Yes, I think actually all the evidence from the essential medicines list is actually has been really helpful. And it has made, going back to again, political will, it's meant messaging to the government to say, look, internationally, there's a recognition that this is the minimum number of essential therapeutics medicines that you must have. That's been very helpful for people locally and nationally making case for particular provision of particular medicines. And I don't see in principle any reason why that shouldn't be essentially the same for diagnostics, to say that, look, these are the 10, 20, 30, whatever it is, internationally recognized and recommended diagnostics. And that we, this country, should be providing that. And to some extent, I would see that almost as a bit of a Trojan horse, if I could call it that. But getting diagnostics onto the agenda to say, look, here as a minimum is what you should have in this country. And if you put an essential diagnostics list in place and then the government accepts that, you then have to say, okay, fine, we may have to have the people who can run these diagnostic tests and have the appropriate quality control, the appropriate regulations for that. So you can actually almost use that to build your diagnostic list, a diagnostic system, as a way of building a system around the practicalities of an essential diagnostics list. So I think the fact that it has been progress in EDLs, it's been important. If we can then use that as a device, or if you like, as a mechanism around which we can then build out the bigger and broader system for diagnostics, particularly from specialized hospitals into the community across that network. So I think that has been important.
Yeah, it is. It is indeed. And I think the next frontier is, can we be able to monitor that progress? I'll give an example at ASLM within our lab mapping project. We kind of sort of analyze, is the current scenario in line with the norm, and the norm now is EDL, or the harmonization list. And it's interesting that in some cases the current scenario is ahead of the norm. For example, maybe some of the point of care tests that have gone into certain areas, but some in many it will be behind. Now, this is in line with taking, one of the key messages that is so clear in the Lancet Commission is nearly half of the world doesn't have access, and you have those 6 marker diseases and conditions, and many of those are actually accessed at the lowest last mile, where many of the recipients of care get access to care. And you mentioned an example of India. They did something for testing at the primary care. Maybe just a highlight of that. How did they manage to try and...
This is actually one of the mysteries to me, in fact, because this was clearly an initiative by the Indian government centrally, in conjunction with states, that they decided that diagnostics was a key component of providing healthcare, which is absolutely true, of course. And they put in place, I think it was called Free Diagnostics, something like that, program, which has been in place now for quite a number of years, 20 or more years, which effectively said that they would subsidize diagnostics and provide them available at even at the lowest components of the community. And that has been very successful. Now, how that happened and who did that and who persuaded the Indian government and the various states governments to do that, I don't know the answer to that. I know people who were involved in the development of the Indian EDL, which was published quite a number of years ago now. Is one of the few, in fact, that includes not just pathology, but also imaging. They recognized the predates.
Yeah.
Exactly. Yeah, absolutely. And in fact, in some ways, it's a great exemplar. And so, and it's an interesting question, and I don't know the answer to them, Anafi, unfortunately. But about, I don't know, 30 years ago, I'm hand waving here, but 30 years ago, people in India managed to persuade the powers that be that this was really important to do, and that's what happened. And I think that, in a way, gives you hope.
Yeah.
because India, 1.4 billion people, a massive country, many, many problems. Clearly, lots of poverty and all the rest of it. If they can do it,
Yeah.
anybody could do it. All of
That's
us can
correct.
do it. And so it can be done. So it's a matter, as it were, of trying to just replicate what they've successfully done, and other countries are doing as well.
Yeah.
So it's an inspiration on the whole.
Yeah. And in that same case study, I also saw that there was mention of involvement of the private sector, mobile laboratories. What will be the key role of the private laboratory sector moving forward?
Again, it's interesting. I mean, my personal view about this is the idea of not involving the private sector, it's not going to work. It won't work. It's just the capacity issues are so large and the resources involved are so large. It clearly has to be involvement of the private sector and the inevitable, to some extent, the profiting that they will make from that, the incentive that provides for them to do it. So, but the private sector in isolation from a government which is willing and were accepting of this won't work. Conversely, a government trying to do it in its own without any involvement of the private sector, in my view, won't work. It's just too difficult, too long. So a partnership is mutually beneficial. And at the end of the day, of course, it's the population, it's the patients and the people of the country who will benefit. So I think there has to be a recognition that it's a joint endeavour and that partnerships are vital for this. And countries, India is a good example of that because a lot of healthcare in India is private, but the government did that in conjunction with the private sector. And as I say, funding the free diagnostics and all the rest of it must have been done in conjunction with and support of the private sector. And so I don't see any reason why that can't exist and work elsewhere.
Yeah. And in these examples, there's a Brazil and there's a component of national health insurance that comes in sort of someone pays somehow for these services in one way or the other. And I think we also see here in our continent that countries that have tried to sort of centralize that. You look at the example of South Africa. Is that the way to go?
I think different countries and it's going to be different solutions. I don't think there's, again, one size fits all. I think countries have to look at what their pre-existing state is, because they will all be slightly different and there will be different stages of development and all the rest of it, and there will be different ways in which they've approached it. So I think you can't say that's the way. So for some countries, South Africa perhaps, that's the way for them, although the national healthcare system there, the national laboratory system there, it has been a challenge.
Yeah.
But again, I don't. My personal view is I don't think it's one or the other, nationalised, centralised versus private and diffuse. I think it has to be both, and we have to find a way in which we can work together, because it's mutually beneficial. And at the end of the day, as I say, I'm going to repeat, it's the patients and the population that benefit from this. And so it's a matter of, again, of trying to make this case advocacy to people that look, because, there's more unites us than separates us. So there's mutual benefit if we can do this. And part of the role of the government working in the private sector, if they can, as it were, provide guarantees of income, either from, amount of cases that they will be involved in or prices which will pay for particular tests, then it's an incentive for the private sector to get involved in and provide the service. So there are ways of doing it. Countries have done it. So again, I don't see there's in principle any reason why that can't apply, although each country is to some extent different. But again, one of the things I mentioned earlier on, I think one of the things we have to do is to try and get more regional, more national advocacy activity, trying to do it all at a global level. It just won't work. There has to be much more. So, for instance, going back to the Global Diagnostic Coalition, which has been launched, one of the things I'd love to see them doing is set up regional subunits, an African or a Sub-Saharan African Diagnostics Coalition, or maybe using, for instance, something that ASLM is doing or CDC is using. But, and doing that is because it just can't all be done and but from a central global perspective. There needs to be more regional, more national advocacy and action and energy from different countries. That we have to get people who know the problems locally, know what the current state of play is. We have to mobilise them and get them to be actually working for their own particular endeavours.
Yeah, I think that's a great point. Coming to regional efforts, one example has been in the regulatory space within the African continent. And I know regulation is one of the recommendations that you had. Maybe in that context, can you unpack what happened so far and where we are going?
Well, you probably know enough better than I do what the current situation is locally. So it's for some ways, this is a good example. Not for me to tell Africa or African countries what to do, because my situation is very, very different. But it's interesting. One of the things, we did several meetings with the commercial sector and diagnostics. So as part of the commission work, we had several meetings talking with the representatives of, the manufacturers. And one of the things, very clear message was they found very frustrating and expensive was having to satisfy regulators in different countries for the same diagnostic tests. And they were urging us to try and get some degree of regional or national harmonization of regulation. And again, it seems to me that's a very clear area where there could be quite a lot of progress made, where regulation for manufacturers could be agreed across. And Africa, sub-Saharan Africa is a good example. Why not? Really, it's not that different amongst different countries that you couldn't have some acceptance that if what the regulatory framework and requirements for particular diagnostic tests are. And I still know there have been initiatives in medical devices in the African continent, and getting that so that manufacturers, if they satisfy the regulator, one regulator, then they could have the whole of the African market to then get recognition.
Yeah, certainly it is promising. Hopefully, with the taking off of armor and trying to harmonize this, hopefully we get there. I want us to move on to another important bit, and wouldn't do justice to this discussion if we don't talk about artificial intelligence and its role in all this. How do you see it?
Yeah, it's very interesting because clearly, not just in healthcare, not just in diagnostics, it's clearly a technology which is going to have an impact. And in fact, imaging is very interesting because quite a lot of AI has become quite established in imaging, and particularly, of course, in high-income countries initially. But that has clearly had an impact and is working. And so I don't see any reason why that will not accelerate. Take my area, which is histopathology. I'm involved a little bit in a couple of companies that are developing artificial intelligence for histopathology.
Yeah.
And it clearly can work. It's more complicated than, for instance, X-rays. But once the algorithms, the software has been written, that's it. It's it can be tweaked and improved, no doubt, down the line. But once it's done, it can be used anywhere. So AI is definitely going to have a significant and increasing role in. So, for instance, ultrasound, handheld ultrasound. I've been for several years now. There've been AI systems which are available, which will help the operator identify where to place the probe. And so, for instance, if they're scanning a kidney or liver or whatever it is, you can say, you're too far to one side. AI will actually help them to identify where they need to be. And then again, help interpret the result and come forward with this is a recommendation from AI. The operator or the clinician doesn't need to accept that, but often will. So I don't think and the rate of development is dramatic. So I can't see. I have arguments with some of my histopathology colleagues, and I say I suspect in 10 years' time, I suspect for a large number of routine histopathology biopsies, so there will be artificial intelligence systems which will give a perfectly acceptable answer, and I don't see in principle why that wouldn't be in place. And of course, some people don't like that. and I don't like it. Thank God I'm, at the end of my career, not at the beginning in a way. But I think it's going to have a huge impact in many diagnostics, and not just in interpretation of images, for instance, in either pathology or. But one of the very interesting things, just one of the companies I've been working with, they've developed a way in which they can scan the request card from the clinician, which I don't know how much experience you've had, but my experience, these request cards tend to be very brief, almost illegible a lot of the time.
Yeah.
And the systems can scan the card, identify the patient, make sure they've got the right patient, interpret the text, and couch that in appropriate language, and all in one scan. And you don't have to, and it's just, so again, that's not being used in, if you like, in a particular diagnostic, but even just around getting the patient sample into the system, that helps to speed up the system, helps to make it more accurate, more reproducible. So it will have a huge impact. And it is happening as we speak. And as I say, I see in 5 or 10 years' time, a lot of what we do currently will be done by AI.
Yeah. And the potential is massive.
Yeah, sorry to interrupt again, but particularly for countries where they don't have much in the way of trained staff.
Yeah.
The AI and the efficiency of the replacement of people for a lot of these activities would be hugely beneficial. Sorry, I interrupted.
Yeah, exactly. No, that's fine. I was going to give an example of that. Like one company approached us in the microbiology context, where AI is sort of capable of then reading the colonies, at least give you a good sense of what this could typically be, and what that could do, to the skills gap that is apparently in bacteriology labs. As you all know, it's about just 1% of the labs within the continent that are capable of doing bacteriology. Again, it's a paradox. We are sort of also looking at a continent where we are saying we are short of health workforce. We have found a solution, but there's also a lot of unemployment among the youth. It means we are not training the people that need to work, but at the same time, AI is potentially there. Some of the critics within this space of AI argue that it potentially widens the inequity gap. What are your thoughts?
Well, that's clearly a danger. There's no question about that. And I presume what people were meaning by that is, this is my interpretation, is that again, the people who have got relatively more money will be able to access diagnostics which is supported by whereas the poorer people can't do that. And I think that's more in a way, that's not an issue for diagnostics, if you like. That's an issue for the society, the governments within the country, to say that these should be as accessible to all. But again, it goes back to, if there's no access to diagnostics, people are paying for it out of pocket. And again, that benefits the richer and disadvantages the poorer people. I think that's essentially the same problem. Whether it makes it worse or not, I'm not sure that it necessarily makes it worse. It might accelerate it. But I think the solution to that is not really a problem, not a solution in the hands of diagnostics. It's actually more a social problem, which has got to do with presumably some degree of regulation or specification, and particularly around insurance systems and the like, and partly to do with affordability. Again, that's an area that might have an impact in that. Just going back a little bit on AI and the workforce, when we were talking about developing multidisciplinary training programs, shorter period ones.
Yeah.
The AI and the impact and the use of AI, it should be a key component of those training programs, it seems to me, so that people can be trained in ways which can maximize the benefit or potential benefits of AI within what they're doing. But as I say, equity, I don't see, maybe there's a cop-out, I don't know. But I don't see that really being a problem that diagnostics can solve. I think that's a social and a political problem.
Yeah, it is indeed, and an integral bit, which, like we said, it will call upon everyone. I think within the AI space, not only diagnostics as well, for regions that are yet to catch up. I think they did. We do need to ensure that we are there. And this links. Yeah,
Sorry, I was
go
going to
ahead.
say, sorry to interrupt actually. I mean, you could argue that in fact, if AI allows us to provide services that are accurate in a timely manner, for instance, in the community by supporting handheld ultrasound or whatever it might be, or lateral flow assay assessment and so on, it actually
Yeah,
can reduce inequity.
yeah,
If we can do this correctly, if we can address the issues properly, actually, it could be a good, strong argument to say that AI will allow us, because of the skill substitution, it can reduce equity rather than emphasizing it.
yeah. And this really links to one of the recommendations that was also highlighted on connected diagnostics.
Yeah.
Yeah,
Well, again, it seems to me fairly obvious nowadays that any diagnostic system being put into place, they should consider how this can be connected into the cloud or whatever it might be, but into a way, in some ways, that it should be connectable, and that
yeah,
therefore, and that where possible, the results of the system should be automatically
yeah,
updated, upscaled into whatever, some sort of cloud-based system. I think that seems to me to be fairly
yeah,
obvious. And again, God help us, going back to held ultrasound, some of these systems now automatically will upload into a cloud-based data system.
yeah. Indeed.
And it can be battery powered, solar powered. The technology is beginning to provide the ability to do this in a way which is diffuse, decentralized, democratized, but also connected. And I think that, that's really a hope for the future. And I think that, that's a point of care testing. It's interesting. I mean, as I said earlier, a histopathologist. We
Yeah,
worked in a hospital lab all my life.
yeah,
But in fact, it's quite clear that if we're going to address providing accurate, timely diagnostics to the 50% of the world's population, which currently has little or no access, that can only come by taking it out of the lab
yeah,
and getting it into the point of care largely. And so the big push in terms of developing technology and people investing and looking at where is the best bang for your buck seems to be has to be in point of care diagnostics.
yeah.
And
Indeed.
they should be connected.
Interconnectedness would kind of solve the other issues that we were talking about. We're talking about the issues of being able to advocate, collect data. And I think it will also help us collect data for the other important piece that I also want us to pivot into: affordability. Looks like it's one area, according to the last year's update, not much progress had
Yeah.
been made. And I'm thinking that part of the problem is maybe we don't have sufficient data to be able to track and make an argument. Can you just unpack where we are globally and what needs to happen?
Well, I mentioned earlier, there has been little, I think it's fair to say, little to no progress on that. And I think and that's because, well, I don't really know the answer to this, of course, but it clearly can't be solved by doing more of what we're currently doing. It's just not going to work. So there needs to be some way in which we can, as I say, taking an example from our medicine colleagues or therapeutic colleagues, they have developed ways over the last 20, 30, 40 years or so where they're making medicines more affordable and more available. And of course, the essential diagnostics, essential medicines list was an important component of that. And so I think what we have to do, it probably requires a global stroke regional approach rather than a more fragmented national or broad level approach to deal with the issues of affordability. And so I think that's, for instance, something that can be addressed, that should be addressed at a more, as I say, regional or global level. And my
Yeah,
personal view is I would like to see the Diagnostics Coalition,
coalition.
affordability would be one of their top priorities. Whether they will or not, I have no idea, of course.
Yeah,
But
yeah,
I just say, it seems to me that's somewhere because it's going to take quite a lot of time to get the manufacturers together with the governments, etc., to address how do we actually provide a way in which a mechanism which will incentivize the manufacturers to make it worth their while to produce these tests, but in a way which then becomes affordable for governments to purchase. And there are mechanisms, as I say, which have been developed to do that in medicines. And I don't see in principle why they couldn't apply equally to diagnostics. But that's going to take time to set up and run. And it's going to take, as I say, a regional or global approach. And I'd like to see the coalition perhaps to address that as one of its top priorities.
Yeah, and I agree.
Currently we have not made any significant progress as far as I know on that.
I do agree. I think the coalition will be a better place. And they do have some examples from the past. I know the Integrated Diagnostics Consortium worked as a multidisciplinary group within the HIV space to sort of bring some prices down. And there have been some all-inclusive global pricing also done. And then maybe other key major donors and procurement entities like the Global Fund have had some multi-country deals, former PEPFAR RFPs that were coming through. I think this can switch to the coalition, I hope. Key element that was so crucial that was mentioned, which unfortunately the world continues to go into conflict, and diagnostics in fragile and conflict areas seems to have stalled. And one, sadly, the example of the ICRC laboratory program shutting down.
Yep. Well, it's interesting because one of our recommendations was that there should be an essential diagnostics list, which is particularly relevant to crisis or humanitarian crisis or emergencies. The WHO has set up a group to do that. They have been working for the last 2 or 3 years, I think, several years anyway. Funny enough, in preparation for this, I did think, gosh, what was happened about that? Because I originally was involved in the advisory group looking at that, but I left that a couple of years ago now. So I actually, one of my colleagues who's still involved, and apparently they're he thinks they're close to finishing, having an EDL for crisis. And so I'm obviously speaking, as it were, without immediate knowledge of it. But my understanding is that fact there will be, the WHO might be able to publish an EDL for crisis, humanitarian crisis and so on, relatively soon. Again, that's the sort of thing the coalition could help, if possible, to make happen. Because, as you say, my God, the number of crises ain't going down, that's for sure. And again, it's very interesting. I know the article, I guess now about 18 months ago. AMR, one of the biggest generators of AMR, apparently, is crisis situations where antibiotics have been handed out without any real insight into whether the organisms are, first of all, bacterial rather than viral, and secondly, are they going to be resistant or sensitive or not? And apparently humanitarian crises are one of the biggest generators of generation of AMR. And AMR is a huge problem and getting a lot of publicity. And in fact, I've been involved in a couple of AR meetings in the last year or two. Very interesting. The AMR community has recognized that diagnostics is a key aspect of addressing the problem of AMR. And if they've taken that on board, again, back to the whole advocacy issue, it seems to me, again, it's a very good and encouraging example of if we can get ourselves sufficiently organized and have the data to make the case, we can make the case persuasively that diagnostics really are important. And AMR is a good example.
Yeah, indeed. That's quite an unfortunately said, but a real need as we move on. We know we've mentioned that diagnostics sort of gained visibility after the Commission, COVID-19, WHO, and things are beginning to move. But of course, certain areas, as we have been discussing, are remaining slightly behind or uneven. But we need to accelerate. we need to move forward. So what needs to happen in the next 2 to 3 years for us to accelerate progress?
My personal view, and I would put a lot of faith or hope into the coalition. If the coalition can actually function with strong leadership, energetic, provide a forum which interested parties can get together, thrash out an agreed program of work which will address the various components we've mentioned: workforce, affordability, innovation, and so on, and put in place plans unifying our effort and showing that people, you deal with this, you deal with that. If we actually can do that, and through the leadership provided by the coalition, and as I say, its role in coordinating, cooperating people, I actually think we can do this. It won't be quick, but it will take time. My personal view is, as I say, unless and until we, as a diagnostics community, can provide a coherent, unified, consistent, persistent voice and address what we see the issues are in a coherent, consistent, persistent way, it's going to be very difficult. So we need unified leadership, unified messaging, unified action. And I'd like to think the coalition will provide that. Maybe it will, maybe it won't. I don't know. We'll see what happens. But it's something like that. It needs to happen. And as I say, as mentioned earlier, I'd also like to see the coalition, because it can't all be done centrally from Geneva and all this, the single. I'd like to see there being one of the developments would be recognising that having regional subunits which can address and encourage the particular problems in one country or one region against the other would be, I think, a good thing to do in that region. But it does need a unified, consistent, persistent voice and leadership and working together. We've done the experiment of fragmentation. Doesn't work. That's partly why we're unrecognised. We're an orphan specialty. This is our chance. We should take that chance and drive it forward.
Indeed, I like that part. Fragmentation hasn't worked. We need to find a way of integrating diagnostics into the whole health system infrastructure. In 5 years' time, what would success look like?
This would look like, I would think, start off just one very basic thing. How many countries have got a national strategy or plan for diagnostics? Has all of them? Have we gone from the, whatever it is, I've forgotten the last number, but 36 countries, has it gone to double that or whatever? What's the angle? What's the trend? What's the change over time? So the first thing would be, have you got a national strategy, including an EDL? And that should be, in my view, that would be a key metric that we should be looking at to see, has that changed? How much has that changed? And hopefully to see that doubling and the doubling time on that. Secondly, have we addressed the issue of affordability?
Yes.
Have we got together? Have we got in place? Have we got plans working? Have we made progress on finding bulk procurement, shared purchasing, and all that sort of stuff? Have we actually learned lessons from that? Can we show that there's been progress in that? Thirdly, has the coalition up and running? Is it providing leadership? Has it, for instance, developed either itself or through other means? Has it provided a coherent advocacy program that we can all say the same thing to our different governments? Or not? Has it produced an economic impact assessment? Has it got data like that? Has that been produced? So I'd like to say, if we can we show progress through strategic countries having plans with EDL in place and developed them? Has globally affordability started to be addressed? And perhaps last on that one is, has the coalition got into place? Is it working effectively as a global forum for leadership and cooperation and collaboration? I think if we could do that and show that that's now working in 2 or 3, 4 years' time, then in the long run, we will make progress. We'll actually help to solve this.
Great. Thanks, Ken. It's been a great discussion today, unpacking this very crucial topic. And as you can see, progress is no longer limited to awareness only. It is increasingly limited to implementation, investment, and leadership.
Yep.
Yeah.
And hopefully we've got now putting in place, have got in place now the mechanisms to provide those both leadership and the investment on the basis of we've persuaded funders, governments that this is a really important integral part of their healthcare system. A great pleasure. Very important problem, very difficult problem, long-term problem, but for the benefit of our populations and our patients, we have to get it solved.
Great. It has been a pleasure hosting Ken on Inside Diagnostics. Colleagues, if you found this conversation valuable, feel free to share it with others working across diagnostics, laboratory systems, and global health. Until next time, stay curious, stay committed to strengthening the systems that do matter. Thank you.